Good evening, everyone. A very warm welcome to the 25th webinar. The topic is on flow cytometry, hematolymphoid cases series. For the talk today, we have our esteemed guest, Dr. Jayashree Kulkarni. Ma'am has around almost 20 years of experience as a consultant hematopathologist. She has finished her MD in Bangalore Medical College and MBA in Sikkim Manipal University. She has been a trained auditor and a NABL assessor. She has worked with various esteemed organizations. She is currently working as a Director, Lab Services and Quality at Sri Shankara Cancer Hospital and Research Center, Bangalore. She has various publications to her credit, and she has provided various guest lectures in CMEs. I'll be handing over to you, ma'am, for the presentation now. Welcome once again, and agreeing.
Thank you, Dr. Naveen. Thank you. I'm audible, right?
Yes, ma'am, you are audible.
And my PPT is shared already.
Can you present it again? It's not visible now.
Okay. Now?
Yes, ma'am, it's visible.
Yeah, it's in full screen.
Yes, ma'am.
Thank you. Thank you for that introduction, Dr. Naveen. Actually, I'm very happy that I've been invited for this talk. I see that post-COVID, most of our learning is through webinars. And I must congratulate Diagnopool for doing this wonderful job, for getting the webinars for the students and those who are interested in learning. I'm sure I too attend a lot of webinars. There is a lot of learning there. Today, what I thought was the topic which was given to me was flow cytometry case studies in hematolymphoid malignancies. From what I understand is, since I am working in a cancer hospital, I see a lot of hematolymphoid malignancies worked up on flow. But for PG students and for the regular diagnostic laboratorians, I have kept it quite simple. The thing is, there is so much, it's a wide topic. So I have chosen a little bit of basics, little bit of principles, how to interpret, and few cases, just to get an overall view of how we do flow cytometry in hematolymphoid malignancies in a cancer hospital. So the flow of my today's flow cytometry talk will be like touching upon the principles and the applications of the flow cytometry, and in particular in leukemia and lymphoproliferative disorders. This I will do in the sequence, normal maturation patterns of the lymphoid myeloid cells, because that is a basic thing which we need to know before we can start interpreting any flow cytometry. We'll see how we choose the antibodies, what is the gating strategy, the spectrum of cases, how the report should be, and what are my references. With this, I'm sure the time will not be enough to really get through to the bottom of every case, but I'll try to do my best. Coming to the principle of flow cytometry, it is very simple: flow, cyto, and metry. What is flow? Flow is the cells are in a motion. So it is a flow. Cyto is a cell. Metry is a measurement. So measuring the properties of cells while in a fluid stream, that is known as flow cytometry. So how does it happen? Basically, there are three parts to it. You have your fluidics, optics, and the electronics. By fluidics, what we mean is the sample is sent in a single stream. By optics, there is the use of lasers and there is use of optical filters and detectors, which will capture the light which is transmitted through the cells because of the complexity. And then these are converted into electronic signals. So the light signals are converted into electrical signals. So the output overall is the particle's relative size, relative granularity or the internal complexity of the cells. And what is most important here is the fluorescence intensity, because that is the property which we are going to use in flow cytometry. Now coming to fluidics. Imagine fluid is passing through a wide bore tubing. So obviously multiple cells will be passing through one particular area. Multiple cells can be passing. So by using a sheath fluid and adjusting the pressure in this sheath fluid, the tubing is narrowed down so that at any given time, only one single cell is passing through this tubing. This is called as hydrodynamic focusing. It produces a single stream of particles. Now, when this happens, now the hydrodynamic focusing and the fluid is here. When the laser light is passed through that single stream of cells, some of the light will pass forward. That is known as the forward scatter. So when the light is passed through the cell, it will only give you the size of the cell, information about the size of the cell. But because of the internal complexity of the cells, the remaining cell light can be reflected at various angles. Now this reflected light is captured and filtered by various barrier and dichroic filters. Now these dichroic filters, they will again allow some more light to pass forward, some light to get deflected. The next filter again passes the remaining light, some of it is reflected. So in this way, we use multiple barrier filters which pass the light only a certain light, say wavelength of 480 to 550, 510 to 550. So based on the wavelength of the light, some light keeps getting out of the filters and getting captured by the photomultiplier tubes. And by this, the various kinds of cells get analyzed. Now, there are various filters by name: short pass filter, long pass filter, band pass filter. These are all for theory. Let us not go into details of it. Let us stick to what is more practical in analyzing this. Now, what happens is, whenever the fluorescence light comes in, the photons get hit by it and they generate electrons. Now, these electrons flow from one dynode to another, and each time they pass from one dynode to another, they gain more and more energy. And the more and more energy, the more and more bigger spike goes on coming. So every single cell that passes through that line will produce one wave like this. So each, on a histogram, you have seen histograms in CBC cell cultures also. So each time a cell passes, the amount of energy it takes and then eliminates, you get a proper bell-shaped curve, or that is also represented by one single dot on a scatter plot. I hope that was clear. So what we discussed just now was either there is forward scatter, which tells you about the size of the cell, or there is a side scatter, which is because of the internal complexity of the cell, and based on the forward scatter, that is the size, and side scatter, that is the complexity of the cell, you have your various WBCs which fall in the different areas. This is simple. You have already learnt it in your cultures. So your lymphocytes are the smallest ones and the least complex. They fall lower on the forward as well as the side scatter. Monocytes are slightly larger and slightly more complex, so they fall here. Whereas your granulocytes or the neutrophils, they are the most complex, very coarse granules. Hence, they fall high on your side scatter and they are also larger in size. So this is the same Coulter principle which is used in flow cytometry as well. However, what is important here is there is use of fluorescence that is used here. So what happens is human eye can perceive the wavelength band from 380 to 700 nanometers, which exists between the ultraviolet and the infrared. Now, using these various fluorochromes of various wavelengths, we can make fluorochromes, which are the fluorescent markers. They can be tagged to the various epitopes on the cells. Now, suppose we are looking at a lymphocyte. Now, this may be a T lymphocyte or a B lymphocyte. If it is a B lymphocyte, we know that it should have either a CD4 or CD8, and it should have CD19, CD20. These are the B markers. Now, based on the fluorochrome, which is tagged to this particular antibody, we will get a dot in that channel. Okay, and you will know that this is a lymphocyte. So this is the basic and simple principle on which flow cytometry is based. Now we have various multiple fluorochromes which are available in the market. FITC, APC, you have the PER-CP Sci-Fi. You should know which fluorochrome is good for which kind of antibodies. So there is a lot of theory on that. You can refer to that. We will not be able to go into details of that. What we should remember is the stronger the fluorescence, you can tag it to an antibody which is very dim. So a dim antibody should be connected to a brighter fluorochrome, whereas the antibody which is in excess, you can use a very dim fluorescence. That is the basic principle. Now, once there is absorption of the light energy by the fluorescent compound, it raises the energy of the molecule from ground state to an excited state. And you get what is known as the excitation and the emission spectrum, which differs for the various kind of fluorochromes you are going to use. And based on the wavelength, there are various channels. Now, flow cytometries have, earlier there were only 5 channels, then it became more modern and they developed 10 channels. Now we have a BD fax lyric, which is a 12 color. So it has basically 12 channels. It can identify 12 different colored fluorochromes, and so many antibodies can be put in the tube at the same time. That is the advantage. So with advancement in flow cytometry, the number of channels are going on increasing. And what is the advantage of this is that earlier when we would put only 5 antibodies in one tube, then we had to repeat the basic markers in the subsequent tubes again, because with every tube you need a basic marker. A basic marker is CD45. As you all know, CD45 is the leukocyte common antigen. So just to know that it is a leukocyte, you have to use a CD45 antigen. Along with that, since you're looking at leukemias, you need to have your immaturity markers, say CD34. So in every tube, you already have 2 antibodies. You can accommodate only 3 more, which are lineage specific markers, say for myeloid or B tube or the T tube. So you used to have multiple tubes. Now with increasing channels, what is happening is in one tube itself, you can fit in multiple antibodies of various lineages and you can have your diagnosis much easier. So as I was telling you, these are various channels in which the various fluorochromes will show up. So FL1 is showing particle A, FL1 is showing particle B. But what if there is some overlap? As you can see in this, the curve is coming down here, but the excitation for channel 2 is beginning of much earlier. So as you see, there is an overlap here. So whichever cells have both the characteristics, they may confuse. So fluorescence, there is an inbuilt program where you can nullify this common light and see to it that your cells get separated appropriately. Okay, that is known as fluorescence compensation. Now, as I told you, once the light gets transmitted and by the PMTs, then it will be produced either as a dot plot or a density plot, contour plots. You want to see whether it is, where are your various populations. You can use your contour plots. Histograms are nothing what you see in Coulter, right? Just to see how broad, how wide your single cell is, whether all of them are of the same size or they are varying in their size, you will be able to appreciate in a histogram. So these are the various plots which you can get the data, but invariably we use a color dot plot for our interpretation in flow cytometry. Can I request all the participants to mute? Thank you. Now coming to the applications of flow cytometry. As you all know, in a day-to-day basis, we use flow cytometry for lymphocyte subset analysis. Patients who are on retroviral therapy, so you need to know their CD4, CD8 counts, you send for flow cytometry. Immunophenotyping of hematological malignancies, of course, is a very good tool to come to the end diagnosis in hematological malignancies. DNA ploidy assay, though you can assess the ploidy in karyotyping, invariably the material may not be enough. You may not get enough metaphases in your conventional karyotyping, but you can do the DNA ploidy on flow cytometry. You can differentiate whether it is hypodiploidy, hypoploidy or hyperdiploidy, and normal. Minimal residual disease. This is when a patient has taken treatment or undergone transplant and you want to see whether there is any kind of minimal residual disease to the tune of 1 in 10,000 cells. Even one abnormal cell in 10,000 cells that are counted can be detected by minimal residual disease. HLA-B27 typing has now come up on flow cytometry, PNH diagnosis, then cell cycle studies you can do, reticulocyte analysis. Another important thing in a cancer setup is the CD34 or the hematopoietic stem cell analysis. So whenever there is a patient who is undergoing a transplant, you need to know how much of stem cells you are going to inject or transfuse into him for a good bone marrow transplant result, right? So for that, we do something called hematopoietic stem cell analysis or stem cell enumeration. That is a different topic altogether. We can do it some other time. Platelet analysis is coming up in a big way on flow cytometry. Not only that, quantification of many antibodies. These are used especially for your, therapeutic purposes also and prognostication also. Now, coming to the basic topic of approach to hematological cases, before going to flow cytometry, I should remind you that you might find this very interesting and feel that that is the end of the story, but no, I would always recommend that we start right from the history, clinical examination, CBC. CBC, not only the counts, scatter plots. Each and every CBC that you run in your lab, make sure that you look at the scattergrams. There is a lot of information which gets wasted if you are not looking at your scatter plots. Just like in flow cytometry plots, which I showed you, I'm sure all of your CBC Coulters have scatter plots, and there is immense. You must see every CBC corresponding scatter plot. That will give you a lot of information. We pick up a lot of leukemia cases with normal CBC counts as we keep looking at the scatter plots. Next step, obviously, is the bone marrow aspiration cytology. What else you can do on the aspiration cytology is your cytochemistry, like MPO, PAS, NSC, and TRAP. These are your cytochemical stains. Next comes the bone marrow biopsy. Bone marrow biopsy, in comparison to the aspiration, the advantage obviously is that the architecture is maintained and you exactly know where your megakaryocytes are lying, Are they paratrabecular? Is there an allip? All those things are better appreciated in your bone marrow biopsy. And on your bone marrow biopsy, again, you can do your immunohistochemistry, which will give you better idea. Flow cytometry, of course. Other than that, cytogenetics, fish, and molecular studies. Nowadays, you must have gone through the new WHO classification. Without cytogenetics, fish, and molecular studies, you won't be able to give the correct classification of what kind of hematological malignancy you are dealing with, right? One thing I would like to say why I prefer flow cytometry over immunohistochemistry is, okay, that in IHC your localization of the antigen is better. You can say that it is a nuclear or a cytoplasmic stain. However, it is much time consuming, labor intensive, and your background staining is much more. Whereas in flow cytometry, though you cannot tell where your antigen is exactly located, one is short time. Within 2 hours, you can really give your diagnosis. You have numerous parameter analysis, the size, this complexity in one go. It's not at all labor intensive. If your technologist is good, well trained, nothing like it. And you can select your cell populations, and then further you can even sort them for further analysis. So flow cytometry definitely has that advantage. Before we go to interpretation, we will quickly run through the maturation pattern of the normal cells. So as we all know, neutrophil maturation goes through myeloblast stage, promyelocyte, myelocyte, and neutrophil. Please remember these three immature markers: TDT, CD34, HLA-DR. Remember them. Every single case, you have to look at the immaturity markers, even to call them a leukemia or leukemia. So you should know whether the cells you are looking at are immature cells or the mature cells. Morphology sometimes can be confusing. That is why these markers are here. The next one to be acquired is CD117. As you all know, promyelocyte is positive for CD117. Then comes your CD64. In between, for a short duration, promyelocyte, myelocyte, it will appear and then it will disappear. However, your lineage markers, now these are called your lineage markers. They define which lineage. So MPO, CD1333, CD15, 11B, 16, and 10. These are your myeloid lineage markers. I think whatever charts I'm going to show, these are from Brentwood. These are taken from Brentwood only, but you can just print them and put it in front of your desk. See them daily. It is very important to know which antigen appears where. Of course, CD45, as I told you, is the backbone marker. So it will be present throughout the maturation. This is your neutrophil maturation. Coming to your other neutrophils like eosinophils, you can look at the high side scatter, and 45 is moderate. That is also positive for 13, 11B, 66, and 16 is a little dim. This is more of morphology. Even basophils, they have a low side scatter compared to the myeloid cells, and they're difficult to distinguish from the lymphocytes and monocytes. But they will be positive for CD38, 123, CD9, 22. These are the useful markers when it comes to basophils. Coming to your erythroid series, CD71 and CD235. For megakaryocytes, it's your CD41, 61, CD42. These are your important markers. Now, coming to the normal bone marrow with monocyte maturation, you have your monocyte precursor or the precursor. Then comes your monoblast, promonocyte, and mature monocyte. So even the morphology, one should be very well aware. You get a convolution, you start getting the convolutions and the cytoplasmic vacuoles, which are much more in the mature monocyte. Again, TDT 34117, they are your immaturity markers. Whereas for monocytes, what you need to remember is HLA-DR is strong and positive throughout. It is a very important marker for your monocytes. As the cells start maturing, then you get your 14 64, and 4. These are your important monocyte markers. So now CD64, as we have seen in our earlier chart, it can also be present in myeloid blasts, dendritic cells, and activated neutrophils. And CD4 is a T cell marker actually. But 14 is the most specific for monocytes. And even if you have seen your WHO classification, they say 2 or more monocytic markers are required to call it a monocyte lineage. So again, these are your lineage markers. These are your immaturity markers. HLA-DR is one thing which is present throughout in the monocytes. Coming to B lymphoid cells, you have your stage 1, 2, 3, 4, and then the mature B cell. So your TDT34, your immature markers, in B lymphoid cells, CD10 appears in the earlier stages, whereas subsequently there is gain of CD79A. CD19, like HLA-DR for monocytes, CD19 is your pan-B marker, right? And CD22, CD20, these are all your lineage markers. Again, CD38 can also be present throughout. Coming to your T cell maturation, again, your immature cells are TDT34 positive. CD7 is your pan marker. Other than that, you have your cytoplasmic and your surface CD3. Now, the initial stages, you'll have your cytoplasmic CD3. Subsequently, you have your surface CD3. CD2 and 5 are again pan T cell markers. CD1A is a very cortical. It's a common cortical thymocyte stage. You get your CD1A. You will see, when you see the cases, you will realize why I'm showing this. Now, CD4 and CD8, you know, it is T helper and T suppressor cells. So initially the cells will be double positive. Later, they can either be 4 or 8. So whenever you get a double positivity of 4 and 8, you know there is something immature about it, right? So this is for your T cell maturation. So this is from Tata Memorial ka SOP, and these are the general markers which we use in our panels also. So you have markers of immaturity, your CD34, DIM CD45 TDT. I'll show you what DIM CD45 means when since CD45, I told it is a backbone marker present in all the cells. But as soon as we say immaturity, CD45 will become DIM, right? Myeloid lineage, we saw that MPO 117, 1333, 1511B. Monocytic, I told you 4, 14, 64 are your good monocytic markers, and bright HLA-DR. Megakaryocytic, 41, 61, 36 also. B lymphoid, your 10, 19, 22, 79, 820. T lymphoid, your cytoplasmic CD3, surface CD3, 1A, 2, 4. See, your 1 to 9 are your T markers, right? You know that now. 10 to 20, 22, and then 170. So it's in that order actually. Plasmacytic dendritic cells are your CD123 and 302. Erythroid series, glycophorin 235A, 71 and 36. Now, other than that, what you should also remember is that leukemia-associated immunophenotypes, in the sense, though this is a T marker, in AMLs, it can come positive. Though this is a B marker, it can aberrantly present in AMLs. Though this is a NK marker, it can present in AML. So these are called leukemia-associated immunophenotypes, right? Similarly, in B and T ALLs, you can get associated myeloid antigen presentation. This is something which you should remember. Now, I already talked about the aberrancy, that is 7/1956, which is common in AMLs. You can also have something abnormal in the blasts or the abnormal in the leukemias, which helps you say that they are abnormal, is the asynchronous. Now, when we talk about 34, we know it is an immaturity marker, but 15 is a mature marker. But if a cell shows co-expression of these two, then there is definitely something abnormal. And not only that, either increased or decreased expression of an antigen, or unusually homogeneous, usually which will show heterogeneous expression, from dim to high, but now it is showing homogeneous. Then that is also a sign of abnormal antigenic pattern. Then once you look at the scatter plots, so invariably we divide them into quadrants. We don't use quadrants in our reporting. This is just for your understanding that I have shown how how markers are mutually exclusive. Like for example, the T cells are CD5 positive, B cells are 19 positive. These are called mutually exclusive markers. But there can be co-expression. For example, T cells can express 3 as well as 7, right? And non-expression. What is meant by non-expression? So they are not showing any of the markers. They are neither CD34 positive nor CD117. This is non-expression. These are the terminologies one should remember. So you should know what is negative, dim, moderate, or bright. So negative need not always lie in this quadrant. It all depends on what kind of control you are taking. So you can either have it in your negative quadrant, or it can be negative in relation to your normal positive control. Okay. So the staining is positive when the fluorescence of any given marker is greater than that of the negative control. And then you categorize it as dim, moderate, or bright. Dim is slightly increased when compared to the negative control. Moderate is at least 1 log decade brighter than the negative. Now, what is log? So as you can see here, it starts from 10 raised to 0 to 10 raised to 1, 2, 3, 4. Each one is 1 log. Okay. So if I am considering this cluster, I can say it is 2 log. So it's a moderate. Whereas this has gone beyond that. So I say this is a bright expression. All this is very relative. And as we go on to see our actual cases, we'll come across this. Now, this is the most important plot whenever you are interpreting your cells. This consists of CD45 versus side scatter. Now, why CD45? We know CD45 is the leukocyte common antigen. And whenever you stain all the cells with CD45 and plot it against a side scatter, so your brightest cells are your lymphocytes and they are small in size. So they are at the bottom. The next ones, lesser, dimmer CD45 are your monocytes, but they are higher on your side scatter. Much less dim cells are your granulocytes. They are very high on your side scatter because of their internal complexity. Your blasts typically lie in this region. They are called dim CD45. We came across dim CD45 when we were talking about the immaturity markers. So your blasts typically lie in this region. A very nice schematic representation is shown just to help you identify which kind of blast. Now, if you see in this one, this is your lymphocytes. These are your blasts. Blasts have to be dimmer than the lymphocytes. Okay. This happens typically in myeloid blasts. They are dimmer than your lymphocytes, but a little higher on your side scatter. Whereas your lymphoblasts, they are dim to negative. So they extend away from the lymphocytes. That is a typical way you will get in a lymphoids. In TALLs, again, so this is your B lymphoid cells, which are dim 45 to negative. TALL blasts, they are much more brighter. So they almost converge with your bright CD45 cells. This helps you in interpreting before even seeing the markers, which are the markers positive. This itself gives you an idea of whether it is a myeloid, a B-ALL, or a TALL, just based on the position in relation to the lymphocytes. When it comes to myeloid blasts, again, this is the M1. This is an old classification, mind you, but it is still there in the WHO NOS, where we give it by morphology. So your M1 blasts are here with M2. Already the maturation has started, hence you are seeing the granulocytes also, mature granulocytes. M3 is because they are the abnormal promyelocytes. They have gone much higher In M4, you have the myeloid blasts as well as the monocytic blasts, monocytic blasts and mature monocytes. M5, so the blasts have gone into the monocytic region, right? That is your M5. M6, so M6 is erythro, so they are not CD45 positive, so they fall in your negative region. Again, M7, they do not take CD45, they are in your negative region. They typically fall in your negative region. So this is a very useful plot. You can save it for yourself and use it whenever you are interpreting flow. How do we regularly go about a normal bone marrow flow interpretation? Now, the first thing is, in a forward scatter area versus height plot, we just choose our singlets. Now, what happens is bone marrow is a very dense sample. There are too many cells, too many debris. There can be fibrin, and then cells can be clumped to each other. So when you look at this plot, you know this area is the area where cells are lying in single. So they don't interfere with your interpretation. If you include this, there'll be a lot of debris. These are the doublets. So you remove the doublets. Now you take these singlets and plot forward versus side. Now again, whatever remains in the left lower corner is again your debris. So you are separating your non-debris cellular events and you take this chunk for your analysis. This is called a non-debris cellular events. Once you take this and plot it in CD45 versus side scatter, you will get the normal distribution like this. Okay, this is for a normal bone marrow. Now, just to quickly look at the normal expression. Now, as soon as you look at lymphocytes, you know they should be okay. Okay, so in a normal sample, majority of your lymphocytes can be T lymphocytes. So do not be surprised if they are CD79A negative, because CD79A is a B marker. But majority of your cells in the normal bone marrow, normal lymphocytes are your T lymphocytes, and hence they are falling here. Whereas your monocytes show dim MPO and your granulocytes show bright MPO. Similarly, your T cells, so they show the cytoplasmic CD3. 7, again, it's a T marker, whereas the others are negative. CD34, you do not expect any blasts here, so there is no CD34. 117, again, it's a immaturity, more immature myeloid marker, so you're not seeing anything here. Coming to the other B lineage markers. So, this is your 4 and 8 nicely segregated, 4 and 8. Your 56 is here, which is an NK marker. So this is how you're going to actually look at all your markers. This is the AML tube. So as you can see, your CD13 and 15 brightly positive, whereas 15 is not positive in the monocytes, but 13 is positive. Your monocytes are positive for 14 and 64. And your 33 is bright and HLA-DR is bright. So knowing these normal patterns, you will be able to solve your cases easily. Now we will quickly run through different cases on flow cytometry using the same principles which I have explained till now. Now this is a 26-year-old male with pancytopenia. Peripheral blood smear showed agranular blast without any features of differentiation. So you cannot call it lymphoid, you cannot call it myeloid, you don't know what to do. So you first resort to your MPO cytochemistry, but cytochemistry is negative. Now that is negative, so we run our flow, and as expected, this is your dim CD45, these are your blasts, lymphocytes, monocytes, and grans. Now concentrate on what all the blasts are expressing. Now we will call them blasts if they are expressing immaturity markers. So your CD34, your TDT is there. So they are immature markers. They are falling in dim CD45. You know you are looking at a leukemia. But what are the other markers? Are they expressing MPO? No. Are they expressing CD79A? No. This is your normal control and it is below your control. So I'm considering that as negative. You don't have 19 in this. So all you have is some 117 and you have 34 and your TDT. These are the markers. So you know it is an immaturity marker and 117 is positive. Once you go to the B lineage, you don't have any 10, 20. So your B lineage markers are negative. Your 56 is negative. And coming to myeloid. Now you saw there was no MPO, but then there is 13 and 33 positive. And your HLA-DR is also positive. Whereas your monocytic markers are negative. So you have immaturity markers and few without MPO, you have myeloid markers. So this is a case of minimal differentiation. From the morphology itself, you knew you were not able to identify which one it was. You didn't have B lineage markers, so you don't call it BALL, no T lineage markers, not TALL. However, you have myeloid markers. You had CD117, 13 and 33. So this is your case of AML M0 with minimal differentiation. Okay, now case number 2, 42-year-old male, fever, lethargy, weight loss, pancytopenia, and it was a known case of AML, so much so easy, and they were suspecting it was a relapse. On morphology, we could see these OR rods, very nice and easy. Okay, so we go to the flow. Now, as soon as we saw that there was some maturation, here also you can see that there are much more granulocytes than you saw in the previous case. So there is kind of maturation which is happening. But in this case, the blasts are positive for MPO. You can see your granulocytes are positive and the blasts are also showing the same amount of MPO positivity. Your cyto-CD3 TDT is negative. 7 can be positive. As I was talking about aberrancies, you know AMLs can show 7 positivity. It is positive in this case, but 19 is negative. 117 is positive. Again, it is a myeloid marker. And coming to the AML tube, you have your 13 and 33 bright positivity. There is no monocytic differentiation. Your other B and T cell markers are negative. All right. So this is a simple case of AML with maturation. So what did you see? Your immaturity markers were CD34. You had HLA-DR, cytoplasmic MPO117, and 1333 was positive. Now, CD19 can be weakly positive and 56 can also be an aberrant marker in AMLs. You should remember that. And TDT and 79A can also be expressed. Invariably, we are taught that CD34 is positive in myeloid markers, TDT in lymphoid, but we often see both interchangeably. It is seen. To case 3, 39-year-old lethargy and bruising gums from the gums, nose. So there was thrombocytopenia, pancytopenia, in fact. Fibrinogen was low, D-dimer. Now, on peripheral smear, you had hypergranular promyelocytes. Some of them were showing like faggot cells. Yeah. So this is a straightforward diagnosis. However, how it looks on flow will be like, there are these blasts and there are then these abnormal promyelocytes, which are then merging into your granulocytes. So what are the properties of these abnormal promyelocytes? We know they'll be CD117 positive. I showed you in the maturation plot, CD117 is positive, but they'll be CD34 negative. Your blasts will be positive, but not the promyelocytes. And then MPO is very strong positive. You know, because of the granularity, you can expect that MPO is strongly positive. Now coming to your other tubes, B, T lineage, no positivity. What is important to note here is those promyelocytes will be HLA-DR negative. Okay, that is one important point which you need to remember when you are looking at your APML. Otherwise, your blast will be positive for 13 and 33 as well. So this was a simple case of APML. What is the importance of reporting APML? It can lead to a hypercoagulable state, and it is an emergency. It is a panic result which you need to inform your clinician so that they can start the patient on ATRA as fast as possible. Now, sometimes we do face difficulty in flow. We are not able to perfectly give them a solution. In such cases, the next thing that we do is a fish for PML RARA, that is translocation 15 and 17. That will be our next step. That is also quite fast. They can give it to you in one day. So ask for fish for PML RARA. And also because CD34 negative, HLA-DR negatives, there is another category of leukemias, which is now categorized as the NPM1 mutated AM. So even that can cause a lot of dilemma, whether you're looking at an APML, especially the hypogranular variant, or the NPM1 mutated AML. Another important feature morphologically which favors NPM1 mutation is the cup-shaped nucleoli. Okay. Now, coming to the next case, that is a 36-year-old female with anemia, thrombocytopenia, and peripheral smear morphology. Obviously, you are seeing some monocytoid as well as promonocytes, monoblast kind of morphology. We are not concentrating too much on morphology because I thought I'll just pay more attention to the interpretation of flow. Now, here, if you look, there are blasts in the dim CD45 region, but there are also these monocytoid cells. So the typical AMML kind of, M4. So what has happened to the blasts? They are positive for MPO, whereas the monocytes, as you can see, they need not be. They can be negative for MPO. And 117 is negative. CD34 is positive. Okay. So these are your positive markers here. So you know you are looking at a immaturity markers, that is CD34. And all your other markers, now 4. As we said, monocytic marker, very important marker is our CD4. And then look at CD14 and 64. So all the blasts have shown co-positivity for 14 and 64. They are positive for 4. And they are also showing the myeloid markers, 13, 33, and the HLA-DR, which is bright. So this is a typical case of AMML, which we used to call earlier. Now it is sufficient to call it AML with monocytic differentiation. So you get CD34 positivity, 117 may not be present, but HLA-DR, this is one differentiating feature between monocytic. So many times morphologically, you might find it difficult to say whether it is a monocytic AML or APML, especially the hypogranular. At that time, HLA-DR is one which will be very useful. In monocytic, definitely HLA-DR is positive. 1333 will be bright, and you have your monocytic markers, that is 14 and 64. Now, MPO most likely will be negative in your monoblast, but can be positive in your promonocytes and monocytes. CD7 and or CD56 can also be found in about 25 to 50% of the cases. So that is your AML with monocytic differentiation. Now coming to another case, smear showed 73% blasts. They were like small in size. Nothing much you can really appreciate from this. Inconspicuous to some conspicuous nucleoli, no or rods there, MPO is negative, PAS is negative. So what are we looking at? Undifferentiated, like the first case. Why would I show you another undifferentiated case, right? So let us see. Now here, again, we have a very dim CD45, almost going to the negative. You see, this is 0, so it's almost touching the negative. Now let us look at the lineage markers. MPO is not there, 79 is not there, so your B is not there, your MPO is also not there, your cyto-CD3 is negative, your 7 is negative, but you have your immaturity marker. So you know they are 34 positive, they are immature cells, they are your abnormal population, but they are also showing your 117. So this is just like your AML M0 case till now, right? But when you come to your B lineage and T lineage, what you're finding here is very bright CD56. Very bright CD56. Please keep it in mind. If it was an AML, your 33 and HLA-DR should have been bright positive here. HLA-DR is negative, 33 is very low, 13 is positive, but 33 definitely is very low. Now with this, we were wondering what kind of a case is this? Is it M0? Most likely it could be M0, but then there is 56 positivity and CD33 looks quite dim. This is not a straightforward case. We went back to our morphology. And what did morphology show? Can you see? There are these platelets coming out of the surface of this cytoplasm. You can see one large platelet here. This gave us a clue. Are we looking at megakaryocytic blasts? Megakaryoblast. So we ran CD4161 and CD41 was positive. I told you megakaryocytes are positive for CD41. So this was our case of AMKL, that is acute megakaryoblast leukemia. In FAB, we used to call it AML M7. Now, typically, these are CD38 positive, but your DR is negative. CD33 will be positive. These are myeloid markers. They will be positive, but you will be confirming it only by running your megakaryocytic markers, that is CD41. So, keeping these in mind, we called it AMKL. And another feature which is important here is your CD56, which is called, there is a terminology called a RAM phenotype. And in such cases, you evaluate the patient for a possibility of a Down syndrome. So do remember, you can have acute leukemias, especially the megakaryoblast leukemias common in these Down patients. The next case, 35-year-old male, lymphoproliferative disorder was diagnosed on a lymph node biopsy. Further, for staging purposes and for flow, the bone marrow was done. What do we see here? Again, we have a blast population which is lying next to it's in the dim CD45 area. But when we come to our A lot, by the way, A lot is acute leukemia orientation tube. So this is our first tube where we put in only our lineage markers. So lineage markers and immaturity markers. Immaturity markers are CD34 and TDT, whereas our lineage markers are MPO and 117 for myeloid, 19 and 79A for your B markers, cyto-CD3 and surface CD3 for your T markers, 7 also for your T markers. So this is our typical A-lot tube, the acute leukemia orientation tube. So in this stage itself, you come to a impression of what lineage you are looking at. But in this case, what do we see? These are your blasts. Blasts are positive for MPO and they are positive for your CD79A. Now, your lymphocytes are cyto-CD3 positive, but the blasts are showing also cyto-CD3. 7 is positive. That means it is a T marker. And your CD34 is bright. There is co-expression of 19 and 34. There is 19. There is some. So literally, you are seeing a myeloid, a B lineage, as well as a T lineage markers. When we further went and did the B lineage and T lineage tubes, again, what we saw was it was 34 positive, 19 positive, 10 was present in some cells. And coming to the myeloid tube, your 13 is also positive, 1464. So basically you have all the 3 lineages, okay? And you would like to call it a mixed phenotype acute leukemia. Very often you see either a B bar myeloid, which is the most common, or a T bar myeloid, and very rarely B bar T. Okay, mixed phenotype acute leukemia. Essential criteria will be more than 20% blasts in the bone marrow or blood expressing combinations of these markers. But they should not be fulfilling the criteria for. Now we labeled it BT myeloid because they had all the three lineage markers. They should not be fitting into either B myeloid or T myeloid. And we have ruled out the cytotoxic therapy and other myeloid neoplasm. This is a very rare case. I just wanted to show it to you. You should be aware that it can present with multiple lineages. Case number 7. So we have by now covered AML M0, AML with maturation. We have seen AML M3. We have seen with the monocytic differentiation. We have seen megakaryocytic, and we have seen the MPAL, that is mixed phenotype acute leukemias. So with that, we have covered all the myeloid lineage acute leukemias. Let us move on to the lymphoid. And typical history, 9-year-old boy and bone pain, fever, and you have these small round cells, more condensed nucleus as compared to your myeloid, inconspicuous nucleoli, and if you are lucky, you get to see this hand mirror forms. So your diagnosis is actually done.
We have around 4 minutes for the meeting to close. I'll ask for an extension if possible.
Okay. So when we do run the flow, so as we saw, blasts were there. They were in the dim CD45 region. And what were they showing? As expected, the 19 and the 79. But as I told you, lymphoid leukemias, TDT. TDT is also positive, and you have other markers are negative. The T markers are negative. Coming to the further tubes, we saw that all the B and T, the T markers were negative, myeloid markers were negative, but you see some CD33 positivity here. Yeah. So these are all aberrant markers. And whenever you see your CD13 and 33 positivity, you should think about your pH positive ALLs. So you need to do your cytogenetics and look for 922 translocation. Okay. So this is all we have covered already. Next case is another 35-year-old male with hyperleukocytosis. Similar case, dim CD45. There is no MPO or 79A. There is no 117 or CD19. But your cyto-CD3 is positive. So are we looking at a T? Yeah. As I told you, in T-ALLs, it literally goes and mixes up with your mature lymphocytes. So this is another important finding. So I think, yes, we are looking at T lineage. We are T4 and 8 co-positivity. I told you co-positivity again tells you about an abnormal population, an immature population. Whenever we get a T-ALL, we need to run our CD1A. We don't do it routinely, and 5. Why this is important? This is important to know whether it is only a straightforward pro-T-ALL or early. Okay, I'll show you the next case where you can see the difference. So here your CD1A and 5 are positive. This is your T-ALL. Whereas another case, similar case, again your CD3 and TDT are positive. 7 is bright positive here. CD34 is also positive. But what is also important to note is that 13, 33 are positive. Whenever in a TALL, you get 13 and 33 without MPO. Now, along with that, if there was MPO, you would have called it MPAL, mixed lineage. There is no MPO, only lineage marker is CD3, but you have 1333. You do run your CD1A and you give a diagnosis of early T precursor provided your 1A and 8 are negative. This is important prognostically. Coming to your mature myeloid lymphoid neoplasms. These are your chronic till here, till the first three steps are the same, CD45 versus side scatter, you know your lymphocytes. The next gating which we use for BCLPDs is your CD19 versus side scatter. And these will be your abnormal lymphocytes. Once they are abnormal, you look at your kappa lambda ratio to see whether they are a clonal population. So as you can see, 98% of the cells are showing only lambda restriction. With this, you know you are looking at a chronic lymphoproliferative disorder, which is a neoplastic clone. Now, for lymphoid B lymphoproliferative, this is a beautiful figure which you can use in your day-to-day practice. So, B cells, based on that, you first look at whether it is a polyclonal or a monoclonal. The first marker you will look at is a CD5. If it is CD5 positive, you look at other markers like CD23 and 200, which is positive in CLL, SLL. If it is negative, then you think of a mantle cell lymphoma. Now, if your 5 is negative, then next marker you look at is CD10 positive or negative. CD10 positivity, obviously your follicular center cell origin. So your DLBCL, the Burkitt's lymphoma, follicular lymphoma fall in this category. Once it is 5 and 10 negative, then you run your hairy cell tube. If these markers are positive, you think of hairy cell leukemia. If these are negative, you think of the other two possibilities, either LPL or your splenic marginal zone lymphoma. Keep this handy, keep it next to your desktop, keep referring it. The case number 10 is this is a spotter, all small mature lymphocytosis, got in a very normal health check. You have these basket cells, yeah, smudge cells. This is in a 65-year-old lady with absolute lymphocytosis. And once we run the flow, you have all of this. Now you please note that there is nothing in the dim CD45. Everything is falling in your bright CD45, which are your lymphocytes. But from that, you need to know which is your abnormal population, which you can see whether how much is a CD19 population. You put it on alpha, kappa and lambda. You look for the restriction. You know it is a clonal proliferation. Then you look at your other markers. So here it is 19 positive. So it is a B lymphoproliferative. Coming to 5. I told you 5 and 23 will be your next markers. As soon as your 5 and 23 are positive, your 200 is positive, your diagnosis is done. It is a case of BCLL, right? FMC7 is usually negative. T markers are negative. So this is what we got. This is a BCLL. Now there are a lot of other criteria which you need to, because of lack of time, I will skip this. Coming to mantle, if your CD5 is negative, your CD5 is positive, but your 23 is negative, think of mantle. Next case, again a spotter. You have a mature lymphocyte, but with hairy projections. So invariably you get a history of massive splenomegaly, lymphocytosis, anemia, thrombocytopenia. And when you look at your flow, these are bright CD19 positive cells. You see, as soon as you get your cytoplasmic fraying, you see that the side scatter has gone up. So they are high on side scatter. And they show kappa restriction. They are 19 positive. And what we do is, we run our 5 and 23, which are negative. 5 is negative, 10 is negative. So I told you 5, 10 negative tumors, either think of hairy cell leukemia or you think of your splenic marginal zone or your other cells. Now you need to look at 10 also, because if it is 10 positive, you'll think of follicular or the DLBCL, or if it is 10 also is negative, then you think of your hairy cell. Your hairy cell tube contains 123, 103, your 11C and 25. So these are positive in this case. So it is your hairy cell leukemia. Very useful algorithm. 10 positive, think of these. 10 negative, either hairy cell leukemia or a splenic marginal zone leukemia. Now, I think with this, I have covered quite a lot of variety of cases. What is important also, is to how to report a flow cytometry. So you give the clinical details, the nature of the specimen, the method, that is stain, lyse, wash. Of course, today we didn't have the time to go into the processing aspects, what equipment you use, what is the test analysis software used, what are the number of events. Now, acute leukemia, 50,000 events is enough to be acquired, but in CLPDs, you will require more. You have to report your bone marrow morphology findings. You choose your strategy, 45 versus site scatter for acute leukemia, 19 versus site scatter for your CLPDs. The whatever the antibodies you are using, and what is the immunophenotypic analysis, whether it is in the dim CD45 or the bright CD45, but which are 19 positive, what are the immaturity markers positive, which are the B lineage, T lineage, myeloid markers, and correlating with this morphology, you give a suggestion of what kind of diagnosis, what hematolymphoid malignancy you are thinking about. These are the guidelines and references which will help you further. And I thank Diagnopool once again for giving me this opportunity. I hope it was a clear presentation. Any questions, you can email it to me or you can call up. I have given my number and my email ID on the first page. You can note it down. I work at Shankara. You are free to come and contact me, come and learn cases from here. Always free to teach. Thank you. Thank you, Dr. Naveen.
Thanks a lot for the extensive presentation, ma'am, and thanks for the offer to learn, which would be, I think, very much useful for us. And you have nicely covered the basics of flow cytometry and went actually nicely correlated the morphology with the markers as well. That was very nice of you, ma'am. Thanks a lot for the detailed talk on this. As ma'am said, if you have any questions, you can write to us or you can email ma'am directly as well. Feel free to reach out to us. And thank you once again, ma'am, for your time.
Thank you, Nandin. Thank you for the opportunity. Thank you.
I hereby close the meeting. Thank you, everyone.
Thank you.